All right. Well, so this one is going to be junctional rhythms. So we're going to talk about where they start. We're going to review the electrical conduction system. We'll talk about what PJCs look like, junctional escape rhythms, accelerated, junctional tachycardia, and then what is going on with the patient with each of these. So the rhythms are always classified based on where they start. So we've already been through sinus rhythms and atrial rhythms. So now we're moving down through the heart, and the next spot is the AV junction. So if the SA node doesn't fire, then the atria do not fire or produce an impulse, then it moves down to the AV junction, and it will assume the role of making your heartbeat. All the rhythms that are in this area of the AV junction are called junctional rhythms. Technically, they're not considered lethal or life-threatening, but if these are occurring, something is significantly wrong, and your patient really needs to be evaluated. It's not one of those go to the doctor tomorrow things. So typically, when the electrical pulse comes from the SA node, it starts here and goes across to the left atria, down through the atria, the right atria to the AV junction, and then down through your right and left bundle branches and into the Purkinje fibers. So that's how it's supposed to occur. But when it fails, the AV junction is going to be like, okay, fine, I'll do that job. So the atria will still typically contract, if they contract at all, during or before the ventricles. Now, if the pulse goes up through this way first and then down through your bundle branches and into the Purkinje fibers. Sometimes it'll go backwards, like we just talked about, and then go back down through here. Sometimes the fire goes pretty much at the same time. And then sometimes it's like, okay, I'll do it. It produces your QRS complex, and then there'll be a P wave because it's a later firing and it goes backwards through the atria, but your P wave will be in your T wave. Remember our firing rates. So your SA node is 60 to 100. That's where we get our standard heart rate from. Then it goes down through the internodal pathways, slowing the impulse back to 40 to 6 at the AV node. Then it goes to your bundle branches, and then if your Purkinje network is a rate of 20 to 40. We already know these. We said this several times. So P waves and junctional rhythms are usually seen before every QRS, but remember we have lead 1, lead 2. So when the AV junction fires the atria instead of the SA node, so the SA node would be up here, AV junction is right here. In normal hearts, it goes this way. So that makes a positive deflection of the P wave. And this is going the opposite way. So instead of being positive and producing a nice little hump, it's going to produce a dip or a divot. So it's going to be negatively deflected. The P wave can also be hidden in the QRS or follow the QRS and be somewhere in the T wave. That's why it's often lost. Your QRS usually is still narrow because ventricular depolarization is normal. In a PJC, or premature junctional contraction, this is an ectopic beat. Remember, it comes before the next expected beat. These are produced from just one site in the AV junction or the bundle of his Purkinje system that is before the next expected beat. If the SA node is depolarized by ectopic beat, there's that non-compensatory pause, and then it resumes the underlying rhythm. I get ahead of myself on these. So for PJCs, the rate is whatever the underlying rhythm is. It's usually a sinus rhythm, and then the PJC. It's usually regular except for the PJC. In the P wave, or in the PJC, it's going to be either inverted or absent or be after the QRS. QRS, the PR interval is usually normal, but you can't measure it on a PJC. QRS complexes are all nice, tight, and narrow. So what we see here is a normal beat, PQRST with repolarization, PQRST, and then this next beat should come about here, but this one came before the next expected beat. There is no discernible P wave, so this is a PJC. Then it picks up the regular rhythm again, and then we have another PJC right here. They're very not common. You rarely see these. They're easier to identify PJCs if it's a sinus rhythm or sinus brady, or if it's some weird bizarre rhythm, then they're kind of harder to pick out. But the important thing is that you pick out whatever the underlying rhythm is and then go back and identify the ectopics. For junctional escape rhythms, the SA node fails to generate an impulse, or if the rate falls below that of the AB node, which is 40 to 60, then the AB node is going to assume the role of the pacemaker. It's a safety feature of your heart. So a junctional escape beat is just an isolated junctional beat, and a junctional escape rhythm is a series of those. And if it falls below 40, it's considered junctional bradycardia. If it's above 60, it's accelerated junctional. If it's above 100, it's called junctional tachycardia. And the next few slides go through that. So the causes are SA node disease, hypoxia, increased parasympathetic tone, so anything, or vagal tone, anything that can cause vagal responses, including different drugs. Cardiac drugs can cause it, or impending complete heart block. These are the rules, which we just went through. So if you look at this rhythm, you can't see this whole complex, but the overall rate is 50. So it's between that 40 and 60. So this is our isoelectric line. Our P wave is inverted. So in the heart, the impulse, the middle is the AB node, so it went this way and produced this negatively deflected QRS, or negatively deflected, negatively deflected P wave, a nice tight and narrow QRS, and then a repolarization event with the T wave, and then all of these are exactly the same. So this is just a plain junctional escape rhythm. Now, if your heart gets kind of irritated, which we call increased automaticity, which means it wants to discharge impulses and it's going to do it a little faster, it's going to be between 60 and 100. This is accelerated junctional. Remember, we can't call anything tachycardic until it gets over 100. So these are the causes. Drugs, this is usually an AFib drug, hypoxia, an impending inferior wall MI, rheumatic fever. These are the rules. We just talked about them. And so the only difference between this rhythm and the last rhythm is we can't really see the whole thing here, but if you go here, there is no P wave. So it's going to be in here. Your P waves will always get covered up in a QRS because it's higher amplitude, bigger electricity. So no P wave, nice tight narrow QRS, repolarization, and they continue. This rate is 1, 2, 3, 4, 5, 6, 70-ish, probably 80 if they finished it out, because here are 3-second marks. So this is just shy of 6 seconds, but it's above that 60 mark and below 100. So we call it accelerated junctional. Junctional tachycardia is exactly the same thing. If you see it stop or start, it's called paroxysmal. And sometimes you can't tell it from SVT. So that's why we group SVT into a group of rhythms, because they're so fast you can't identify all the components that you would need to. These are the causes. Ischemics or lack of oxygen in the heart, a blockage, something like that. Stimulants, energy drinks, anxiety, hyperventilating, hypoxia, DIGE, rheumatic heart disease, and then treatment is just figuring out what's causing it and eliminating that. So here's what it looks like. So you can't see a discernible P wave. Your rate is going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So over 100, because there's probably another one here. So around 110, 120. And it's just junctional tachycardia. The significance of junctional rhythms, it indicates that something is wrong. The more that they have, the worse the problem is. But it's usually not very serious, if they have more than 6 per minute, we call this frequent. So you can label your rhythm frequent PJCs with a overlying rhythm of a sinus rhythm. And usually they're a precursor to other things going wrong. So we observe these and try and figure out the cause. Junctional escape rhythm. You look at your patient. Remember, that's what we treat first, not a machine. The rate's 40 to 60. We look for signs that the patient's compromised. They have decreased perfusion. They feel weak. They feel like they're going to pass out. They're having trouble maintaining consciousness or sitting up. So what we want to do, if we see decreased perfusion, we want to O2 IV monitor. We're going to consider some drugs, and we'll talk about those drugs later. But a lot of patients just sit in this rhythm and they look perfectly fine. Accelerated junctional, this is the one between 60 and 100, usually well tolerated. If they're on DIG, I would go ahead and run levels, monitor the patient, know that this can turn into something more serious and very quickly. Junctional tachycardia, usually well tolerated. If they already have a cardiac issue, then you're going to see them be more clinically deteriorated. They may say things like, I feel my heart beating in my face, I can feel it in my neck, it feels like it's fluttering, or I can feel my heartbeat. And we base our treatment on what the patient is doing. O2 IV monitor, fluids, start running labs. Let's look at these strips. All right. So this strip, the rate is 1, 2, 3, 4, 5, 6, 7. So around 70. These are our P waves, and they're significant because they are all inverted. So this is accelerated junctional. This one, the heart rate's 30. There are no discernible P waves. This is just regular junctional rhythm. Or you call it junctional bradycardia if you wanted to. This one, we have a sinus rhythm, and then we have a little guy. Oh, I'm sorry. This is bigeminal. Yeah, bigeminal PJC. So normal sinus rhythm beat, inverted P wave, normal, inverted, normal, and then we have a PJC here. It came early before the next expected, and then it resumes back to the sinus rhythm. You can measure out your PR intervals and all that stuff, but it's a sinus rhythm with bigeminal PJCs, and then another ectopic one here that came a little early. This one here, no discernible P waves. The rate is over 100, so this is junctional tachycardia. This one, we have a P wave, QRST, can't really find a P wave there. And then P, PJC, P, PJC, P. So it's bigeminal. I love you. I'm doing stuff. I'll see you in a bit. This one, the rate is 70, so it's above 60. There are no discernible P waves. QRS is nice, tight, and regular. No other ectopic beats. Everything is regular, so this is accelerated junctional. This one, heart rate's 40, falls within that 40 to 60. QRS is narrow, no discernible P waves. This is just regular junctional rhythm. This one, heart rate's over 100, no discernible P waves. I mean, I guess maybe you could count that, but that's kind of a reach. It is regular, so this is junctional tachycardia. All done. That's it.